This presentation is about fluid biomarkers for mild cognitive impairment and early dementia. Let me first repeat some basic principles that are needed to understand the mechanisms behind the current fluid biomarkers. What exactly is Alzheimer's disease? In Alzheimer's disease, two proteins play a major role. The first one is amyloid. Amyloid forms amyloid plaques in between the neurons. This is the earliest detectable change in the brain of AD patients. A second protein that plays a major role is the protein tau, that is part of the cytoskeleton of the neurons. And in Alzheimer's disease, it gets phosphorylated. And these phosphorylated or hyperphosphorylated tau proteins form deposits within the neurons that we call neurofibrillary tangles. A next step in the pathophysiology of Alzheimer's disease is the degeneration of the synapses, which leads to a degeneration of the brain network. And this leads to what we call brain atrophy. The volume of the brain reduces, the mass of the brain reduces, and this can be visible on the brain MR scan. In Alzheimer's disease, the atrophy is maximal in the medial temporal lobe region where the hippocampus is located. Let's have a look at this slide, at this figure. We look at the inner surface of the right hemisphere. And the red color depicts the spread of the neurofibrillary pathology. And the darker the red color is, the higher the density is. This represents a patient with early dementia due to Alzheimer's disease. The damage is enormous. If we go back in time, mean interval of 5 years, then we have here a patient with mild cognitive impairment. And also in this earliest symptomatic stage of Alzheimer's disease, the damage in the brain is important. So that means that the neuropathology or the first neuropathological lesions occur years before the first symptoms occur. And we now know that the first amyloid plaques and also the first tangles occur 10 to even 20 years before the first symptoms of Alzheimer's disease. And this insight has changed our concept of Alzheimer's disease dramatically. We now know that the disease is a continuum with a very long preclinical stage, during which the pathology builds up, but the person, the subject, has no symptoms yet. This stage is followed by a stage of mild cognitive impairment, a pre-dementia stage, and then subsequently the dementia stage is the terminal end stage of the disease. This model shows you different biomarkers that change from normal to abnormal over the continuum of Alzheimer's disease. If you want to go for early diagnosis, you should look at the red curve. This is the earliest detectable change in Alzheimer's disease. This is the amyloid curve. Right now, amyloid positivity is a part of the new research diagnostic criteria, which means that you cannot diagnose Alzheimer's disease for research purposes anymore without proof of being amyloid positive. Let's now have a look at the existing fluid biomarkers for Alzheimer's disease. The cerebrospinal fluid offers a window to the brain. And so it reflects the brain metabolism, and also pathological changes that occur in the brain can be detected in the CSF. To acquire CSF, we have to perform a lumbar puncture, which is of course an invasive procedure that is, however, well accepted. Biomarker analyses in the CSF are relatively cheap, and it offers not only information about the amyloid status, but also on other biomarkers, like, for example, the tau markers in the CSF. Changes in the CSF occur very early in Alzheimer's disease. Amyloid can also be analyzed by means of an amyloid PET, which is not invasive, but the accessibility of PET scans is limited, as it is an expensive technique. An advantage of PET as compared to CSF biomarkers is that you get topographical information, which can be important. Amyloid PET changes a little bit later than the CSF changes in Alzheimer's disease with regard to amyloid. But the question is if this is clinically relevant. But of course, to acquire CSF, we have to perform a lumbar puncture, which is an invasive procedure. A couple of years ago, within the context of a JPND consortium, we performed a multi-center European study to look at the performance and the complications of lumbar punctures in memory clinics. We saw that the acceptance rate of lumbar punctures was high. It was higher if there was a clinical or diagnostic reason to perform the puncture as compared to research purposes to perform the puncture. We were surprised to notice that 31% of the subjects reported post-lumbar puncture complaints. But the number of severe complaints requiring a blood patch or requiring a hospitalization was very low. What were the most frequent complications? In case of unsuccessful lumbar punctures, a so-called dry tap, 35% of the people reported back pain, and 8% of the people reported headache. In case of a successful lumbar puncture, the number of people that reported headache was higher, but only 9% had typical post-lumbar puncture headaches. How come that these complication rates were that high? Well, we saw that there was a huge variability amongst different centers with regard to the lumbar puncture procedures. And so that's why we have written consensus guidelines for lumbar punctures in order to strive to reduce the complication rates after lumbar punctures. Based on our multi-center lumbar puncture study and based on a literature review, we published the following recommendations in order to lower the prevalence of post-lumbar puncture complications. The lateral recumbent position reduces the prevalence of post-LP headache. The same holds true for the needle type. This is the most important determinant factor for post-lumbar puncture headache. And if a 25G atraumatic needle is used, the prevalence of post-LP headache is low. We recommend a maximum of 4 LP attempts, as more LP attempts increases the prevalence of lower back pain after the lumbar puncture. Free flow is better than aspiration of CSF with regard to the risk of post-LP headache. And up to 30 ml of CSF can be collected safely without increase of post-lumbar puncture headache or other complications. Bed rest or local anesthesia did not influence the prevalence of post-LP complaints. What can be analyzed in the CSF? First of all, amyloid beta of 42 amino acids, which is the main constituent of the amyloid plaques. In Alzheimer's disease, the levels of A-beta 142 lower as compared to controls. Total tau reflects the normal tau proportion in the CSF, and it increases in Alzheimer's disease due to neurodegeneration. P-tau reflects the formation of neurofibrillary tangles in Alzheimer's disease, and it also increases in AD. Now, if we look at the diagnostic accuracy of these Alzheimer's disease CSF biomarkers, as compared to the autopsy confirmation of the diagnosis, then we see that if we want to separate Alzheimer's disease patients from controls, the diagnostic accuracy significantly increases by using these biomarkers as compared to the formerly used clinical diagnostic criteria. If we want to separate AD dementia from non-AD dementia subjects, the diagnostic accuracy significantly increases when biomarkers, the core AD-CSF biomarkers, are used. In this exercise, AD versus non-AD, the diagnostic accuracy of these biomarkers is a little bit lower as compared to the former exercise, AD versus controls. This is caused by overlap with regard to the AD-CSF biomarkers in Alzheimer's disease versus non-AD dementias, and also caused by the fact that in some non-AD dementias, there can be Alzheimer co-pathology in the brain. Do these core AD biomarkers in the CSF also allow early diagnosis, for example, in the MCI stage of the disease? In this slide, we see a figure from Hanson et al., published in 2006. A cohort of MCI patients was included, and these subjects received a lumbar puncture at baseline. And the cohort was followed up for 60 months, 5 years. The blue curve shows you the patients with normal biomarker profiles. And almost all of them did not progress to dementia. The red curve shows you the subjects with pathological CSF, pathological biomarker profiles, and almost all of them developed dementia during the follow-up period of 5 years. At that time, we said, wow, nice, those biomarkers are able to predict dementia amongst MCI subjects. Nowadays, we say, nice, these biomarkers are able to diagnose Alzheimer's disease amongst MCI subjects, and with sensitivity and specificity values that are quite high. And these findings have been replicated in several independent cohorts. How can these AD-CSF biomarkers be used in clinical practice? What are the recommendations? These AD-CSF biomarkers serve to diagnose Alzheimer's disease in the earliest stages of the disease, when diagnosing Alzheimer's disease is more difficult. So they can help to diagnose Alzheimer's disease in the MCI stage. They can also be used to increase the diagnostic accuracy in case of early onset Alzheimer's disease or young onset Alzheimer's disease. These patients can have atypical presentations of Alzheimer's disease, and biomarkers can significantly increase the diagnostic accuracy in these patients. The AD-CSF biomarkers have their use in case of diagnostic doubt, in case of atypical clinical presentation, or in case of clinically ambiguous diagnoses. For example, one doubts between is this Alzheimer's disease with frontal lobe features, or is this an early frontotemporal dementia? They can also help to diagnose the Alzheimer's disease component in people with mixed pathology, for example, significant cerebrovascular disease. And the CSF biomarkers, of course, serve to identify AD subjects to be included in clinical trials. What are the limitations of these CSF biomarkers for Alzheimer's disease? A huge problem with regard to the AD-CSF biomarkers is the variability, and there are numerous sources of variability. This slide shows you all the potential pre-analytical sources of variability. The most important one is tube adsorption. Amyloid beta is a sticky protein, and in case of the use of glass tubes or polystyrene tubes, it sticks to the tube wall and leads to false low A beta values. Therefore, it is very important to use polypropylene tubes for collection as well as for storage of the CSF. What can be done to reduce the variability of the AD-CSF biomarkers? Well, standardization and harmonization are very important. The European JPND Biomarker APD Consortium has significantly contributed to the standardization and harmonization of these Alzheimer's CSF biomarkers. Another measure to be taken is the use of a certified reference material and a certified reference method for the value assignment of assay calibrators. Another helpful measure is the use of the CSF A-beta 142 over A-beta 140 ratio. A-beta 140 reflects the total pool of A-beta, and this ratio is more disease-specific for Alzheimer's disease, and is also more reliable than when A-beta 142 is used alone. This is also depicted here. At the left side, you see the use of A-beta 142 alone. Right here, this is the ratio that has been used. The blue bars shows you the subjects in which the findings of the CSF biomarkers or the CSF A-beta measurements were concordant with amyloid PET. And you see that the concordance significantly increases when the ratio is used as compared to A-beta 142 alone. Another problem is the overlap between Alzheimer's disease and non-AD dementia subjects. One explanation for this overlap is the occurrence of AD co-pathology in the brain of subjects with non-AD dementias. This is very prominent in patients with dementia with Lewy bodies. In our series of autopsy-confirmed DLB patients, 78% had amyloid pathology, co-pathology in the brain. And this is also reflected in the AD-CSF biomarkers. The subjects with DLB that had amyloid plaques in the brain had comparable A-beta 142 values as compared to autopsy-confirmed Alzheimer's disease subjects. This is a known pitfall in subjects with DLB. What can be done to increase the differential diagnostic accuracy? Well, first of all, p-tau is the most specific marker for Alzheimer's disease. It is very useful when you want to discriminate Alzheimer's disease from non-AD subjects. The use of the A-beta 142 over A-beta 140 ratio is also helpful, as this is more disease-specific as compared to the use of A-beta 142 alone. In the future, we need to develop biomarkers that are specific for non-AD pathologies. and that can be added to the core AD-CSF biomarker panel. But this is for the future. Can the core Alzheimer's disease biomarkers be used for monitoring disease progression? Unfortunately not. In these three figures, we see the measurements of t-tau at the left, in the middle A-beta-142, and at the right p-tau in subjects with Alzheimer's disease that received 2 lumbar punctures with an interval of 2 years. And the AD biomarker values remained remarkably stable despite 2 years of disease evolution. How come? Well, this can be explained by the fact that, for example, for the A-beta-142 curve, it reaches a plateau as from the symptomatic stage of the disease on. So these AD-CSF biomarkers cannot be used to monitor disease progression. We will need other biomarkers to monitor disease progression or to predict disease progression. Right here, you see several CSF biomarkers that can be used to monitor disease progression, the increase in Alzheimer's disease. Some of these biomarkers are biomarkers for neural injury or for neurodegeneration. Some are markers of synaptic dysfunction, and they seem to occur a little bit earlier than neurodegeneration. The problem with these biomarkers is that they are not specific for Alzheimer's disease. This is very well known for tau, as it increases significantly after stroke, or it also increases significantly in subjects with Creutzfeldt-Jakob's disease. Anyhow, neurogranin might be a promising biomarker to predict disease progression, albeit a non-specific marker for Alzheimer's disease. But it seems to predict future rate of cognitive decline. It predicts rate of volume loss and brain atrophy, and it also predicts a reduced cortical glucose metabolism on the FDG PET in this study. What will the future bring with regard to fluid biomarkers? Well, one research focus is, of course, blood. And we see that plasma A-beta-142 is quite good in separating AD patients from controls, almost as good as CSF A-beta-142 is. Plasma A-beta-142 is still under investigation. It is being validated at this moment. Plasma A-beta-142, as well as the A-beta-142/140 ratio, is currently under evaluation, and we expect it to be a promising biomarker for pre-screening purposes, for example, for clinical trials. Those who are positive in plasma will need a lumbar puncture or an amyloid PET for confirmation of the amyloid status of the subject. But by means of using this plasma ratio of A-beta, the number of subjects that have to undergo a lumbar puncture or an amyloid PET can significantly be reduced. What can we conclude with regard to the fluid biomarkers for MCI and early dementia? We now have core AD-CSF biomarkers that are very well validated and that significantly increase the diagnostic accuracy, also in the early stages of the disease, being the earliest symptomatic stages, the mild cognitive impairment stage of Alzheimer's disease. However, we may not forget that these are biomarkers for Alzheimer's disease, and that we do not have the biomarkers yet to diagnose non-AD neurodegenerative brain disorders that can also cause mild cognitive impairment. An advantage of early diagnosis might be advanced care planning. The subject is able to plan his or her care in advance. We may also not forget the right to know or the right not to know. If a subject, a patient, does not want to know that he or she has the incurable disorder, Alzheimer's disease, that's his or her full right. And we should not proceed to biomarker diagnosis of the potential Alzheimer's disease in the subject. These biomarkers may not be used in the preclinical stages of Alzheimer's disease in routine clinical practice. This can only be done in research for research purposes. We need to develop and validate new fluid biomarkers that are specific for non-AD diseases in order to increase the differential diagnostic accuracy. We also need better and other markers to monitor and even predict disease progression, as the current markers that correlate with disease progression in Alzheimer's disease are not specific for Alzheimer's disease. And we need to validate biomarkers in blood, as blood has the advantage that it is less invasive. Blood sampling is less invasive than a lumbar puncture, of course. I thank you for your attention.
Thank you very much for a great talk, Sebastian, on fluid biomarkers in MCI. I see that we already have a couple of questions on the chat, but I'd like to once again open the floor for everyone for questions. So please let us know if you have any questions and use the chat function. So I think I will start up with a question from Andre, who asks about the profile of biomarkers in the CSF when it comes to diagnosing primary progressive aphasias, so language variants of frontotemporal dementia.
Yes, very good question. In fact, those primary progressive aphasias can also be an atypical presentation of Alzheimer's disease. So if you want to demonstrate or rule out or even show that the subject with primary progressive aphasia has atypical Alzheimer's disease, then it is, of course, of use to perform a lumbar puncture and to analyze the core Alzheimer biomarkers in the CSF.
Thank you very much. And I guess that also goes to the fact that we know that these aphasias are typically caused by specific pathologies, such as, for example, logopenic aphasia is typically at least associated with the amyloid to a higher degree than the others, than semantic dementia, for example.
Yes, indeed.
I had a question with regards to the slide where you showed the correlation between the correlation between baseline tau and tau at 2-year follow-up, where you showed this very, very nice correlation, which somehow is in contrast with what Rick showed with regards to the correlation between tau uptake and cognitive impairment. And I'm just wondering, why is there so little dynamics in this measure of tau? I'm thinking sort of an analogy to the liver, where you have leakage of liver enzymes due to the fact that hepatocytes are dying off and releasing these enzymes, and somehow I would expect the same thing happening when neurons die off, that we have this tau leakage, and that if you had a lot of dying off of neurons, then you would see a spike in tau. Is it just because that the rate of neurodegeneration is the same, or is something else to do with the biology influencing these findings? What are your views?
A very good question. Not every part of the brain has the same impact on the CSF composition. So that might also play a role. For these CSF biomarkers, it is well known that they reach a plateau in the CSF as from at least the dementia stage on. It might be different if you would look at the earlier stages of the Alzheimer continuum.
Okay, thank you. There's a couple of questions on the chat. There's a question from someone just signing in as R, and the question is if we in the future could use the markers to, I think, discover probably preclinical disease, like in a massive health protocol. So I think it is a question with regards to screening, using biomarkers, fluid biomarkers.
Yeah, so the CSF biomarkers are used nowadays to diagnose, between hyphens, preclinical Alzheimer's disease for research purposes. Of course, this is not done for clinical practice for several reasons. And one of the major reasons is that we do not have a disease-modifying treatment yet. CSF is used for research purposes. It will not be a good screening tool, of course. The liver puncture is too invasive. So for that purpose, we would need blood biomarkers that would serve as a screen or a screening tool. And afterwards, if the screening is positive, you would probably still need a confirmation test, like a PET scan or a lumbar puncture.
Yes. Then there's a question from Alex, which I think is a very relevant question also. He asks, with regards to the role of determining alpha-synuclein in CSF. So is this, I guess this has been tried, but there must be some difficulties, or is it on the way? What are your...
Yeah, it's a very difficult marker. First of all, the levels of alpha-syn in the CSF are very low. So you need a very sensitive technique. On the other hand, it has been shown that alpha-syn levels in the CSF more reflect the neurodegeneration than really the synucleinopathy itself. So we struggle with this marker. And it's still research that is ongoing. It would be great to have a good marker, a reliable biomarker for synucleinopathies. It would be of use in clinical practice, of course, but yeah. So we still cannot use it, certainly not in CSF.
Okay. And then there's a question from Georgie, I think also a real hot topic. It's on the use of neurofilament light, both in serum and CSF. So the question is it appropriate in the near future to use a neurofilament light chain in serum and CSF?
It's under investigation as well. We expect neurofilament light to be an appropriate marker that is correlated with neurodegeneration. It might have some predictive value with regard to cognitive decline, but this still has to be demonstrated and validated clinically. Neurofilament light also has some more or less specific, is a more or less specific marker for frontotemporal dementia. I say more or less specific because it remains an unspecific marker that also increases in Alzheimer's disease, for example. So it's under investigation, but it is a promising marker, and I think it will have somewhere, somehow, a place in the diagnostics of neurodegenerative brain disorders.
And would you care to guess whether, or is there any evidence to suggest that this that neurofilament light might be more dynamic with regards to in comparison to tau? Is there anything to suggest this?
It is very well correlated with tau, so okay. That is still under investigation.
Then there's a question from Maria. I guess the question is on false positives and false negative biomarker levels with regards to beta amyloid, and I guess also maybe a bit relating to this issue that we see incongruency with regards to beta amyloid, amyloid PET and CSF levels. Can you comment on that?
Yeah, so with regard to this question, again, it's very important to use the A-beta 142 over A-beta 140 ratio in CSF. If you have a so-called high producer and the A-beta 142 lowers a bit, but still remains above the threshold, then the result, the biomarker result, would be normal, not indicative for Alzheimer's disease. Whereas in this case, if you use the ratio, then you would see that the ratio is below the threshold, and that this case would be indicative of Alzheimer's disease. This is because A-beta 140 reflects the total pool of A-beta. And in our ENTROP experience, I think about 1 person on 5 or on 6 had normal A-beta 142 levels, where clinically Alzheimer's disease had increased t-tau and or p-tau levels. But when we used then the A-beta 142 over 40 ratio, we clearly saw that this one on 5 or 1 on 6 high A-beta producers had abnormal ratio values, and so were indicative for Alzheimer's disease. So the use of the ratio should be encouraged firmly.
Then there's a question from Mustafa with regards to the ratio between beta amyloid 42 in CSF and plasma. If anyone has looked at that, and if this is relevant with regards to the diagnostic procedures in AD.
Yeah, so we have very good indication that this ratio in plasma performs better than A-beta 142 in plasma alone, but it remains a screening test. We think that it has no diagnostic accuracy is not high enough to be used as a diagnostic test, but this is still under investigation.
Okay, thank you very much. I think we are. There are no new questions on the chat function.
I see a question about brain biopsy.
Oh yeah, sorry. So if, I don't know if that's within your area of expertise, but whether brain biopsy, if it can be done safely, would solve our doubts, and whether there are any efforts with regards to developing technology in order to get the brain biopsy safely.
Yeah, well, the main problem there is where do you perform the biopsy? If you perform it in a brain area where there is not a lot of pathology, then the brain biopsy will be normal or negative.
Yeah, so that's an issue with all brain biopsy, that you might come away with normal brain tissue.
Yeah.
So what are your thoughts on biomarkers of astroglial changes? Rob asks.
Biomarkers of astroglial changes are also aspecific markers. They can be of use. They might be correlated with, for example, disease progression or neurodegeneration, but are, as far as we know at this moment, quite aspecific.
Okay. So let's see. Sanjay has a question. Is it possible to measure beta amyloid oligomers of various lengths? Have there been any hypothesis-free methods, e.g. machine learning, to detect ratios that might have good sensitivity and specificity?
Yeah, you can measure amyloid oligomers of various lengths. But A-beta 142 seems to be the most affected in Alzheimer's disease, and the 42/40 ratio is, as far as we know now at this moment, the most disease specific for Alzheimer's disease. hypothesis-free methods have been tested, but again, leading to the same conclusions.
Okay. Thank you very much, Sebastian. I think we do not have time for any more questions, so I would just like to first thank all of the attendees who tuned in to this virtual teaching course on diagnosis of MCI and early dementia. And thank you for all the great questions that you posted on the chat. And also thank you very much to my co-speakers, Jonathan Schott, Rick Ossenkoppel, and Sebastian Engelborgs for some really excellent talks, I think, and some excellent Q&As. Thank you very much, and have a great conference.
Thank you. Bye-bye.
Thank you so much, everybody. See you next year, hopefully.
Great.
So are we...
I'd like to thank the organisers very much for the